All right, we are recording and we are now live.
Well, hello, everybody. How's everybody doing out there in DSN? Thank you guys so much for joining us live. And if you aren't catching this live, I'm sure you're catching us some way, one way or another, either inside the document or video vault or catching the replay of this. Today, I'm super excited because we have Chris Richards with us and Dr. Taher Dhoon from the Colorado Surgical Institute. And we're going to be talking about sedation. This is actually a really exciting time for us over at Colorado Surgical Institute. We have sold out the majority of our classes all the way through 2023. But one of the new projects that we're going to be working on is an IV sedation course, a full IV sedation course. And we're going to talk to you guys a little bit about the course today, but this isn't intended to be a commercial. We're also going to be talking about physiology and pharmacology and sedation itself and how to integrate that into your dental practice. So welcome, Chris and Dr. Dhoon. How are you guys doing today?
Doing great.
Really great, man.
Yeah. So coming at us live from Denver, Colorado, Greeley, Colorado, and Denver, Colorado is Chris and Taher today. This is your admin day today, Taher, and you decided that you were going to pop on for a webinar, so I appreciate that. Tell us what we want to be covering today and what our big plans are for Colorado Surgical and how we're going to integrate sedation training into our current curriculum.
Yeah, awesome. Well, I appreciate it. First and foremost, I mean, we came off of the course last weekend, our full arch course, and
biggest one ever.
Yeah. And I want to show this quick video and just, talk about, why we do what we do and like the transformations that we can have in our practice. And so this video is thanks to Chris and his team, but this is what we did last weekend.
You just look at your teeth, girl.
All of you are so kind to this. It's hard being so insecure for so long. I love you, Daddy. I love you. Thank you all.
Yeah, 16 arches in 3 days with block grafts, laterals, all of the above. So
yeah, 102 implants,
right.
120 cans of Red Bull. I probably personally consumed about 20 of them.
Yeah, I think it's the only time I drink Red Bull is at those courses.
It's how long ago was it? A week? I haven't slept yet.
Man, less than a week. It's
Yeah.
crazy to think, but so, I mean, we still have a couple of spots open in the May course, but we are sold out for March and June and into September and all of the above. So it's a really cool ride and appreciate the DSN family for supporting us on that. Also, I want to talk about the Dental Startup Masterclass real quick before we dive into sedation and fentanyl and Versed and all those fun topics. But essentially for anyone who's starting to do a startup, acquisition, merger, expansion, we're going to do a two-day intensive in terms of just how you do that, how you save money through the project. Like currently I'm building an 18-op practice and it's a ground up. So we're doing the exterior architecture, we're doing the interior, obviously, and we're learning a lot about what's happening within the current economic industry, legislatively, economically, technologically, and all the changes that are occurring and how to apply that to doing this build out. I mean, even the implementation of like Chat GPT and asking questions about the design. So everything is just changing so quickly. And Chris Green, who's not on this webinar, obviously right now, is a wealth of knowledge on this subject too.
Yeah, it's going to be fun. We would love to see some DSI friendly faces there in Houston. It's going to be at the Vauxhall facility, which is a brand new, beautiful state-of-the-art facility. Vauxhall's been a great supporter of all things DSN and CSI. So we would love to see you guys there. And let me just tell you this, I've had 16 dental practices, 6 of them were startups. And if I had a course like this before I started building out and doing all of my de novos, I would have saved so much frustration and hundreds of thousands of dollars. So we're going to start by showing you kind of all the mistakes that we've made and show you exactly how to kind of navigate around those obstacles. So just that alone is could be a whole trajectory changer for your practice, for your new practice. And if you're expanding as well, or if you have a new acquisition, a newish acquisition, and you're thinking about expanding at some point, this course could help quite a bit.
All right. So now to what everyone showed up for. It's like, well, why do we actually want to do sedation in our practices? So first and foremost, I mean, there is a huge, huge population of patients in everyone's geographic territories that need a form of relaxation, sedation, whether it's minimal, moderate, or deep. It moves the needle in a major way. And when I do all these coaching calls with DSI clients, and typically the calls I'm doing are based on surgery, and they're going to be based upon how to grow production and how to increase your productivity per hour. One of the first recommendations I'm making is incorporation of oral sedation or IV sedation into your practices. For me, I did oral sedation for about 8 years before I implemented IV sedation several years ago. If I had to go back and do it again, just knowing what I know now, I think I would just go straight for IV sedation and do that implementation from day one versus oral sedation. There's no knock on oral sedation. However, if we just look at the revenue that it can build and the way that legislation is changing in the states, a lot of them are going to require IV sedation to even have people do IV sedation in your practices. So either way, it's a practice builder. If you think about it, even if you don't market this, from an internal referral perspective, people talk, and you can have a friend say, "Oh, I had a root canal. My root canal was really bad," and then the next friend just says like, "Well, I had a root canal and I don't remember any of it, and it was the most amazing experience, and you should go see my doc." So you're initially just building your internal referrals and your reputation in the community. It allows you to do more work in one appointment per patient, which absolutely is going to increase your productivity per hour. If patients have gag reflexes, that turns off with sedatives. You can also, put some alcohol right here on the chin and put the file right in their chin. Mark, I don't know if you've ever done that, but a little bit of Eastern medicine with some acupuncture points, which can also turn off the gag reflex.
Oh, I didn't know that. That's cool.
Yeah, if you look on social media, they have all these posts with people with these goopy impression materials in their mouths and a file right in their chin.
Huh.
Number 5, the patients are relaxed, their blood pressures are lower. You pop in the mouth prop, you just get to work. You can add different surgical procedures to the mix, like wisdom teeth, different more advanced all-on-4s, implants, sinus lifts, whatever the case may be. Most parents do not want their kids having their wisdom teeth out without any form of sedation. A lot of parents are okay if the kids have oral sedation or IV sedation. They don't need to see the oral surgeon anymore. And wisdom teeth is super low hanging fruit. Absolutely. The overhead is really low. Nowadays, it's like 15, 20 minutes in the operatory, and then you're in and out and off to the next thing. I also like it when you can just sedate the patient and you can have candid conversations in the operatory. You don't have to be the doctor. You don't have to be on all the time. You can have conversations with your team, kind of pick their brain on what's happening in the practice. And then the last thing that I think is it moves the needle the most is there's a psychological thing with patients where they have no problem paying for the procedure 100% in full before they ever come into your practice when they know they're being sedated. Their cancellation rates are lower. They make provisions in their lives where their loved ones know what they have to do, and they are there at the practice. And the cancellation rates, I can't say are zero, but they're like next to nothing.
Excellent.
And so if we look at different strategies in terms of implementation of sedation, you can have nitrous. I haven't used nitrous for about 8 years. So from that perspective, at the new build, we're going to plummet. But if you have nitrous, this is just a random price you can put to it. But nitrous and supplemental oxygen is absolutely a must. Oral sedation, you can charge around $250 plus or minus. If you're the dentist administering the IV, I charge a flat fee of $500 for it. My overhead on it is probably like $25. So just the profitability of doing it just in itself as a procedure on its own makes sense. And then if you're going to call in your CRNAs, your anesthesiologists, CRNAs are running in our area about $750 for 2 hours. And then your traditional anesthesiologists are running about $750 per hour. So what we charge in our practice is $1,000 per 2 hours, and then in 15-minute increments on top of that for the CRNAs. If you are looking for CRNAs or anesthesiologists, but you don't know where to look, you can call your pediatric dentist. A lot of them are doing a lot of general anesthesia in their practices, and they have a lot of different groups that they work with. So they're a good resource. And then obviously like Facebook groups and DSN and just reaching out to people you know. One tip and trick to make the transition into IV sedation as easy as possible is doing phlebotomy in your own practice now with the implementation of like PRP and PRF and those things. When I got IV certified, I think the hardest thing for me was just finding veins in those like really meaty guys with the veins are like deep into their arms. And then if you start doing your own blood draws, you're going to get way more comfortable finding the vein. And then at that point, it's much easier than you think it's going to be. But in the beginning, if you want to get reps right now, implementation of PRF into your practice is absolutely a no-brainer. I mean, the centrifuges are a couple $100. The cost per case is maybe $10 or $11, and you can charge about $100 to $200 per quadrant per PRF site.
Yeah.
Some verbiage I use with patients is like, look, I don't want to sedate you 6 separate times to do all this work. Let's go ahead and get you scheduled for everything, and they prepay for the appointment, and you spend one whole morning with the patient and just take care of everything. Ideally, do the sedation consult that day, lock down the financials, get the consent forms and everything done, scans and pictures and whatever you need. But if you're at capacity, don't throw off your whole schedule with an hour sedation consult. Bring them back in for a consultation. And sometimes I will actually waive the fee on these bigger cases. It's just like an act of goodwill for the patient. Where I'll waive, the $500 charge to do a $15,000 case, and then the patients feel like they're getting something out of it, and they're very thankful for it. Or you could just tell them like, look, hey, if you're willing to do a marketing video, I'll waive the $500 IV sedation cost too. So it's a good way to build your practice from a marketing and reputational perspective. A couple of the codes associated with it. We can probably set up some kind of post on DSN, or already exists, where different docs in different regions have different prices and how they build this out. But these are some of the codes you guys can look into. If you look at the right-hand side, these are just kind of the requirements with the ADA for IV sedation. You need 60 hours of didactics, and you need 20 live patient cases to submit to your state board. So what we're doing is we're breaking this out into 2 virtual components. So you don't have to travel out 4 separate times to see us at the Colorado Surgical. It's going to be 20 hours virtual and in June, and then 20 hours virtual in July, and then 20 hours in person where we're going over, mannequins and different types of ALS training and stuff like that. And then you come in and do the live patient surgery or anesthesia components with us. So hopping into patient evaluation, arguably one of the most important things you can do. First off, I'm going to kind of share a story where I broke my own rules and the negative effects that can occur from it. So MPO rules, right? Can't eat, they can't drink. The patient comes in, she's 21 years old, and she didn't follow the rules, and she ate 4 hours ago. And this is one of the times where you need to stick to it and you don't break the rules, because, you know, I was like, all right, well, you took time off work. She gives me the sob story, and I end up actually, you know, sedating her, and I keep her light, and everything was fine from that perspective. But then she calls the next week and she's like, oh, guess what? I'm pregnant, you know, and we had already reviewed everything. We had talked about everything. If I had just followed my MPO rules, and I know these are two mutually exclusive things, we would have avoided this situation. And we asked her about the pregnancy. So one thing we're recommending everyone do or consider doing in your practices is buying just really cheap pregnancy tests. Before the patient comes and sits in the chair, you want them to go to the bathroom anyways. You don't want their bladder to be full. So any woman of childbearing ages, you just have them go take a quick pregnancy test and then hop back in the chair. It definitely will save you maybe once a year, maybe never, but it's a good practice. Mm-hmm. And then we're going to go into airway examination, and then we're going to touch on ASA statuses. We're going to review the organ systems, you know, how to select the lower risk patients, like those more optimized patients. And then we're also going to determine, you know, the patients where you're going to bring the CRNA into your practice, and then the patients where, you know, they aren't getting sedation, or they're going to go see, you know, the oral surgeon, and the oral surgeons exist for a reason. And just always remember, right, stick to your rules, because it's always easier to stay out of trouble than it is to get yourself out of trouble. So patient evaluation, I'm not going to go through every single bit of this. You'll have your form, you'll kind of check it off, but you're going to review past medical history. I like reviewing their past surgical history, because I like talking to them about, you know, well, did the anesthesiologist wake you up and say, hey, you had a bad reaction to this? Or did you take a long time to wake up? Or are you a tough stick? You know, you don't want to go searching for a vein on someone where, you know, the anesthesiologists have a hard time. On those cases, you automatically want your anesthesiologist to be present to find the vein, because they might have to go to the foot, or they might have these small little 24 gauges that they can find for the patient. Absolutely, review of systems you got to do. On vitals, the only thing up here I'm not doing is taking a temperature on patients. I think that's, you know, what you're going to consider doing when they're very deeply sedated. Medications, herbal supplementation. There should be no reason why a patient should be on herbal supplements coming into the procedure. I think it's wise to have them stop. When it comes to labs, I think if you're ordering labs for a patient to find out if you can sedate them, you might automatically be considering CRNAs and anesthesiologists to do the case. If they're otherwise healthy and they're ASA 1 or 2, then you can, you know, do the case yourself.
Do you have a favorite software or resource for checking contraindications or drug kind of interactions with the sedation drugs?
You know, I think ChatGPT would be really cool. I haven't used it in that respect. I'm trying to use it everywhere now, but more so than not, I just kind of hop on, you know, WebMD or one of those. I don't keep the app on my phone, but I know Hippocrates and some of these other ones do exist out there. Cool. But it used to be free, and then I don't know what they charge these days. And so when we look at our ASA classifications here, you know, 5 and 6 and 4 should never be in your practice ever. 3s should really be with the CRNA or anesthesiologist. And then you can do 1s and 2s, or dependent upon the 2, if it's like a 2.5, that's when you bring your CRNA in as well. And then some of the operative risk factors you want to evaluate, right? You're going to look at their age, comorbidities, the extent and duration of the procedure. As soon as I'm starting to get to 2.5 hours or 3 hours into the procedure, I'm going to consider CRNAs to be present. The patient can have a paradoxical reaction where the Versed just, you know, it just stops working. It just becomes not effective anymore, no matter what you give them. And then with the fentanyl, you know, fentanyl is good, right? And you can kind of keep them controlled on that end. Some docs can use propofol in their states. Some of you guys can use ketamine as well. In the state of Colorado, I can only use Versed and fentanyl. So for me, after a certain amount of time, it's no longer really going to move the needle for the patient to keep them truly sedated. It just kind of keeps them comfortable. You're going to look at the skill set of the surgical team, duration we already talked about, equipment you have, and then just post-operative care. So airway examination, this one's important for sure. I think a rule of thumb, instead of like having a checklist on this, is if the patient can open up and you can get 3 fingers within that range of motion, that's a really good rule of thumb to know that, you know, they can open up enough for you to do the procedure in itself from a dental perspective, but B, if intubation or anything is needed, you know, the anesthesiologist can intubate. Also check their protrusive movement, because if they can't advance the mandible forward enough, then you can't kind of do that chin lift for them and open their airway. When it comes to intubation, none of us are going to be intubating. That's kind of out of our scope. Our job is to stay out of trouble. And if for whatever reason there's an issue, we get the bag, we keep them ventilated, call EMS. We are going to be reviewing some of the scary stuff here. What I will say is we've never had, I'm going to knock on wood, never had to call EMS or have any of these issues occur, because the case selection that we're doing is going to keep us out of that territory. Consents, super big in this area, right? Just like any major procedure, get consents, really good documentation. If you don't have it written down and you didn't document it in the court of law, it never happened. It's prudent to say no to ASA 3s and 4s, right? Just know that if you say no to the patient, it's in their best interest. It's not about the money associated with the case. MPO rules, we kind of talked about, 8 hours for food, 6 hours for dairy, 2 hours for clear liquids. I prefer that they only hydrate with enough water in that 6-hour period, so they're just not like dehydrated. I also prefer that they don't have coffee. And then also I would consider strongly a charge associated with them breaking MPO rules, meaning you have to cancel your procedure because they didn't follow the rules. So consider that as well. So the fun stuff we learned that's now finally applicable from dental school. You know, it's like, well, what is pharmacokinetics, right? If we think about it, it's just the whole body is doing the drug. And then what is the route of delivery, the absorption, the distribution, the metabolism, and the elimination of the drug. So for us, the big ones are sublingual, oral, and IV, maybe IM. None of you guys should be doing any rectal administrations in your practice for whatever reasons. And then maybe inhalationals via nitrous oxide. Routes of delivery, so sublingual, you know, the benefits of that is it bypasses the first pass effect. So by putting, and what we do in our practice is we'll crush it up and we'll just pour it under their tongue, have the patient lift their tongue up, and then they put their tongue back down and we start the timer. You can also mix it up in a little elixir and have them drink it if you like, but that's obviously not sublingual. But it's just different ways to administer the medications for the patient. The first pass effect is, you know, the liver is metabolizing the medication. For the medication getting into the under the lingual mucosa into the venous outflow, that is going to get directly into the patient's system, and you're going to have more efficacy of the medication that way. If you're taking the pills orally, there's multiple reasons why you could have absorption not be as strong. And so from that perspective, I mean, you know, if they have delayed gastric emptying, if they have diabetes, if they have antacids or the pH in the stomach is different, all of that will slow down the bioavailability of the drug for the patient, as well as then the liver metabolization of the medication too. So some of the times on the upper right side, you know, oral medications can take 30 to 90 minutes. Sublingual can take 3 to 5 minutes. Anecdotally speaking, in my practice, sublingual takes way longer than 3 to 5 minutes.
Yeah, I've never seen anything take 3 to 5 minutes sublingually. Even if you crush it up, it doesn't. That's way too fast.
Yeah, maybe the literature is saying if you, I don't know, inject it sublingually, I don't know, but in my practice, we're still waiting 10 to 15 minutes for sublingual. Yeah. IV, 30 to 60 seconds for sure. We're not going to talk about transdermal. And then bioavailability of the medication. IV, you know, by definition, should be theoretically 100%. And then the Oral administration, like we talked about, it's more convenient to take it that way, but it can be 5 to 100% depending on the patient. So how are drugs metabolized? Again, we have 60 hours of didactics that covers a lot of curriculum. I'm going to just do the bird's eye view. So just in general, right? It goes through hepatic metabolization. Factors affecting it are going to be patient's age, very young, very old. They're going to be, variable in how they're going to absorb it based on the albumin levels and various different things with them. Do they have any hepatic diseases, any cardiac diseases that's changing the hepatic blood flow, pulmonary when you come to the inhalationals, any endocrine dysfunctions or drug interactions. We all know half-lives. A good rule of thumb to kind of understand is if the half-life on something is 1 hour, it takes about 5 hours for that stuff to get out of your system. I think the Halcyon, taking a PO, has a half-life of 2 hours. So then you can theoretically think, okay, it's going to take 10 hours for that to get out of their system. If you've done oral sedation long enough, you're going to have elderly patients saying, well, I was sedated all the way into the next day. Well, that's also because that stuff remained in their system. Their body wasn't able to process it as quickly, so they stayed sedated for a much longer period of time. And then if you look at what's called context-sensitive half-life, essentially it's a good predictor of how long the clinical effects of the drug will be present. So there are going to be some patients who are sensitive to sedation, some who are standard responses, and some who require additional sedation. It's always better to start low and slow on people versus giving them a standard dosage right off the bat. You can always administer more. Like we said in the beginning, it's always better to stay out of trouble than try to reverse it. So how does the liver metabolize the drugs? It goes through oxidation, reduction, conjugation, and hydrolysis. We learned the CYP450 system, and then another one that's important is CYP3A4. So the reason why the CYP3A4 is important is because it's going to take into effect how acetaminophen, dexamethasone, fentanyl, lidocaine, midazolam are all metabolized. And those are the major ones. Those are the ones that we're all predominantly going to be using in our practice. So there are some things that are inducers of the CYP3A4. And some of that is going to increase the rate of drug clearance, which means the patients will need more medication than expected. And then we put some of the medications here on the right side. And there are some things that are going to be inhibitors. And so from that perspective, the patients will need less medication than expected. And then the big ones are SSRIs, post-COVID. We saw an influx of people who had more SSRIs and TCAs and antidepressants on, in their systems. And then also from an implant perspective, we did see an uptick in implant failures associated with SSRIs and TCAs as well. So definitely add that to the list of questions you're asking patients, either when it's surgical or when it's coming to sedatives. So a few things on the pharmacokinetics we just need to understand is that there's rapid distribution and there's a slower distribution. So from the central blood volume, it's going to be more rapid. From the peripheral blood volume, it's going to be a little bit slower. And then the terminal phase of the drug is when you have medication absorbed into the tissues, and then a longer procedure, more is absorbed into the tissues. And then when you wake them back up, it's released back from the tissue into the plasma. So then it can kind of dictate how long the patients take to wake back up as well. So big difference between the efficacy and the affinity. So efficacy of the drug is the level of activation of the receptor, and the affinity is how much of the drug can bind to the receptor at a given concentration. And then this one's important as well. The ED50 is the dose required to produce the specific desired effect in 50% of the individuals. The LD50 is the dose required to produce death in 50% of the individuals. And then that ratio between them is called the therapeutic index. So the higher the therapeutic index means it's a safer drug to give to the patients. So we're going to get into airway examination. This kind of dovetails a little bit into how you talk to patients about sleep apnea as well. We can probably do another webinar on sleep and adding sleep to the practice and the revenue you can build that way. But one thing to consider also is when these patients are sedated and when they're just on room oxygen, and they're minimally sedated, you can see their oxygen levels decrease. And if they're staying and baselining at a low oxygen level without supplemental oxygen through like the nasal cannula, I mean, I think it's a safe bet to say that there's apnea, and you can ask them to get tested. And I think it's advantageous for us to carry some tests, because then you can charge $3,500 per sleep test. You have evidence through the sedation that they've desaturated numerous times over. And then the patients are more willing to then go into oral appliances or get a CPAP after the case as well. So I guess, for example, the case we did yesterday, she comes in 18 and 32 need to be extracted, young, healthy female, she's in her 40s, pulse ox is on, she's at 92 on room air. So we give her some supplemental oxygen, keep her at, 98, 99, and then we start the sedation. Then we keep her at like 94 the whole time. But then as she left, we gave her the sleep test to take, and she's probably going to sign up and do a appliance with us. And I would be, I'd put money on it that she's probably moderate if on room air she's just baselining at a 92. So some of the things, hopefully we never have to use mask ventilation for patients, but we all need to know how to use it. And there will probably be the time when you do IV sedation in your practice that you have to grab the mask. So from that perspective, a couple of things to look at that make putting that bag mask on more difficult. Lack of teeth, that might be a byproduct of the procedure you're doing. Presence of a big beard, history of snoring or sleep apnea, abnormal head and neck anatomy, those thick necks that they look like retired linemen, their necks are as big as like my thigh type of scenario. Mallampati 3 and 4, age, over a certain age, males, and then limited jaw protrusion. So here is a slightly blurry, I apologize for that, Mallampati schedule. So essentially it goes 1, 2, 3, 4. 1 is you can see uvula, airway space. They open up, you can see straight down the airway. Mallampati 2 is kind of the uvula almost connects to the base of the tongue when you're visualizing it, and you see like 2 different windows into the airway space. 3 is you really only see soft palate, and 4 is you can't even really see the soft palate anymore. And again, this Mallampati classification is going to be used in your sleep apnea evaluations as well. And it's good to see this because you're going to find out like, hey, can this patient maintain their own airway if we're going to be sedating them heavily? Just another, descriptor of what's going on. You got the nasal pharyngeal airway, oral pharyngeal airway, a lot of musculature back there that's going to drape back into their airway and close things off. And then ventilation. The hope is you never need to ventilate a patient. The reality of it is you will probably ventilate a patient, once a year if you're doing enough sedation in your practice. But we've selected the cases where they can maintain an airway, and you can do this very easily. So one important thing is the FiO2, the fraction of inspired oxygen. Essentially, I mean, it's plus or minus wherever you are, but 21% of the gas mixture in a room is going to be oxygen. And so a good rule of thumb is like, okay, well, what's their oxygenation beforehand with that level of oxygen? And then if you need to give supplemental oxygen, and I recommend that, most patients, you'll just keep supplemental oxygen on at a very low dose, you're going to be increasing that percentage of oxygenation coming into the lungs for the patient. You can definitely hook up your oxygen to the bag and then get a good seal with this C-shaped seal. Sometimes you have to do a two-handed technique and the assistant has to, pump the bag for you. But it's good to get reps. It's good to do the training on this stuff. You can use oral airways and nasal trumpets. I don't think there's a place for us really using nasal trumpets in our practice because we're not sedating people deeply enough where they're going to be comfortable with that and they're going to be trying to mess with it because they're going to be moderately sedated. It's more for the anesthesiologist to use in the practice. Most of what we're going to be doing is just the chin lift or the assistant can grab the teeth and pull the mandible out as well to help open the airway if they deset, and then you just crank up the supplemental oxygen to like a 4 up until the point that you get to your A or A minus, and then you can take it down a little bit. Just another picture of some of the ventilation. It is important to have, it is important to know how to use. Just know I know EMS can get to my practice in 6 minutes. Again, oral airways, nasal trumpets, all of these things that we should know how to use, but we pray we never have to. Okay, so doing ambulatory surgeries and things you just need to consider. There's MI, there's stroke, there's PE. It's probably not going to happen in our practices. I think the ratio or the percentage of that happening in our practice because of sedation is next to nothing. I think it's really like, hey, if that patient was going to have a stroke or heart attack or anything, that was going to happen in your practice if you're doing local. But more minor complications, the big ones are pain. You got your post-operative nausea and vomiting. So what we do for that is we're giving a lot of patients dexamethasone. We're just going to go 4 milligrams. So we get, 1 cc of it. The dexamethasone is an antiemetic as well. It helps post-operatively with swelling significantly. And so we're giving them dexamethasone through the IV. We're also using a lot of Toradol through the IV unless there's like bleeding reasons or reasons they can't take ibuprofens. And you can have like drowsiness after the fact, and you have to allocate time for recovery. Hypotension, hypertension, different meds that can be used to counteract that. And then bleeding, byproduct of what we do as well. So I think the major thing, and we experience this actually at the course, is the social aspect where, they don't have an escort, or their escort's not reliable, or they're not monitored at home properly. So we really have to be intentional about like, hey, does this person have someone in their life who cares about them, who can take care of them for a couple of hours after they leave the practice? I think that's an important indicator too.
Good point.
So, and then we got something in here about COVID and upper respiratory infections and stuff like that. Okay, so non-operating room anesthesia. So again, a couple of the things to consider is your ASA guidelines, your physical location is going to meet your local and state guidelines. When you get credentialing for your facility, they send someone out to ensure that that's going to happen. And usually the people coming out are really nice, and they're going to just kind of give you advice on what you need to have ready, and how you're going to set up your office to pass the inspection. You need to have extra e-cylinders for your oxygen. That's an absolute must. Reliable suction. You're going to want to have extra, ideally if you're doing a new build or anything, your surgical operatories, you're going to want to have like extra electrical outlets, a little bit extra space. You don't have to build the 20 by 20 operatory. You can still have it be 9 by 12, but just kind of, construct things in a way where you have room for people. And then, yeah, you need a defib that works, and emergency medications that hopefully just collect dust and expire, and then you have to replace them when the time comes. A few that are good to have is hydralazine and labetalol. All of those will decrease blood pressure. One will decrease blood pressure and pulse, and one just decreases blood pressure. But also if someone is blood pressure is really high and they're not as sedated, you can also just give more fentanyl and bring their blood pressure down. Like at the course, we had a guy, surgery was running, long, and he was kind of tapping out, and his blood pressure went up to 200 over 100. We just gave him a little extra fentanyl. He got more comfortable. He was out of pain. His blood pressure returned back to normal. So that's sometimes a good trick to control blood pressure as well.
Cool.
And then when we look at minimal and moderate, we theoretically should never be having a patient enter into deep sedation or general anesthesia. We want our patients to have no airway intervention required at all. Like that is the goal. So we have to do our case selection in a way where we don't have this problem. And then getting down to just some of the things, I usually will use a 22 gauge, which is the blue one. I stock a few yellows. So sometimes if you got to go to the hand, or I've had to go to the foot once on a sweet little old lady. And she was very sweet, like her hand won blue, and she was just, dehydrated from the day before. That's why you want them to hydrate really well the day before. You can use a smaller yellow one and the pink ones. I don't really carry any of the 18 or 14 gauge needles in my practice. It's mainly 20s and 22s. And then IV placement. So this one, I think when you do, it's harder to teach this over a webinar in terms of how to feel the vein. I think it's something you need to get out to a course and feel it, or do some phlebotomy in your practice. But essentially, it's going to feel like a little trampoline. You're going to depress it a little bit, not with your thumb, but with one of the fingers, and you're going to kind of feel it bounce back up. And you'll be surprised. Your assistants will get better at this than you will if you let them do all the phlebotomy in your practice. I have one assistant currently who's I think still better than I am at this. And so every once in a while, Michaela will show me up if I can't find one, and she'll come in and save the day. But at the end of the day, you can go anti-cubicle area right here above the elbow. I go to the hand a lot as well if it's nice, because then the patient's arm won't bend during the procedure and obstruct it. So you have a lot of different ways to kind of implement this into your practice. But essentially what you want to do is you place your tourniquet. You have the patient pump their fist a few times. You can get a warm towel. They have like different vein finders and ultrasounds and cool apps on your phone that you can use if you want to. But at the end of the day, if you're screening your patients at your consultation appointment better, and you're finding out if they're a hard stick or easy stick, and you have them roll up their sleeve and you look at it, hopefully you're not going to run into any problems on the day of the procedure. And then you want to wipe it with alcohol and get the skin clean. We're going to wipe in a circular motion kind of away from where you're going. And then keep the skin nice and tight so the vein doesn't roll. A lot of the superficial ones can roll. The deeper ones have more tissue around it, so it holds it a little bit more stable. But for me, I see the superficial one. I like going for it. I like going for the ones I can visualize. So hold it nice and tight. And then you'll advance the needle in until you see the flash. And then you'll bring it a little bit flatter and more level and parallel to the arm. And then you'll advance the needle a little bit further. And then you just push your catheter in. You can screw on the tubing or have your assistant screw it on, and then release the tourniquet. And then you just check and make sure you're getting a drip, which means you're in the vein. Tape it up on the arm. And then if you feel for whatever reason, maybe you missed, or it was so deep that you were searching a little bit and then you had to find it, and you don't know if you're having fluid kind of drain into the arm, you can just look to see if there's like a little elevation occurring there. If there's no elevation, you're in a vein, you're good to go. All right. So I know we have a little bit of time left. I didn't necessarily want to talk and put down all my IV cocktails on here, because everyone is different and how they're going to handle it. But right off the bat, typically what I'm doing for a wisdom tooth case is, and if let's assume ASA1, healthy patient, not 90 pounds soaking wet, and not 250 pounds, just a regular average person, you can start them with 2.5 of Versed. Once you get more comfortable, you can probably do 5 milligrams of Versed, and you can probably do 50 to 100 of fentanyl. I know Sean Custer has a really good protocol. He's one of our mentors at the Wisdom Tooth course. I mean, that guy can do probably 16 wisdom teeth in an hour. He just boom, 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 super, super efficient. And so you can do Versed and fentanyl right off the bat. I like to do my fentanyl first, and I'll push 100 of fentanyl, and then I'll do 5 of Versed. And then at that point, they're getting really, really drowsy. But then I'll go straight in with the anesthetic, no topical, and I'll push it a little hard. So they're kind of getting a stimulus too. So they're not, they're getting kind of stimulated through that initial depression that's occurring. And then by the time I go from the upper right to the upper left, to the lower left, to the lower right, anesthetic has kicked in enough where then I can start extracting right away, upper right, upper left. And I go in the same rotation, and you're just in and out of the operatory very, very quick. So that's typically what I'm doing. And then I'm usually waiting 20 minutes or so before I'm going to do another administration. We always have supplemental oxygen going. So then their O2 levels are always good. always putting a throat pack in. There should be no reason anyone aspirates anything because a throat pack is always in place. And then your team is recording everything. So you have someone recording everything, making sure all the vitals and things are good, and one assistant who's a rock star assisting you on the procedure.
So, Dr. Dhoon, what are some extra expenses that we can anticipate? You don't have to have the exact dollar amount, but I know, we'll need a pulse ox, we'll need some sort of oxygen delivery if we don't have it. We're going to need an IED. What other things are absolutely mandatory if we're going to switch over to this protocol?
Yeah, you're going to need your capnography units. You're going to have allocate for extra payroll for these procedures to have another assistant kind of pop in and make sure they're recording everything properly. Mm-hmm. And then when it comes down to like all the needles and tubings and saline and all that stuff, I know saline's a little bit more expensive right now, but with everything else kind of added in, the big ones it's the CE to get it going. It's paying for the credentialing for the office. It's your capnography unit, which is sometimes a couple $1,000 depending on where you go. And if you want one that integrates with software and, all of that, you don't need to go and get the most lavish thing out there, because for us, we're not doing sedation 24 hours a day all the time in a hospital setting. Mm-hmm. So I kind of recommend, just kind of getting the bare minimum of what you need to do this safely and record it per state and federal law. And then later down the road, buying fancier toys. And you'll need some backup stuff too. You'll need to get a bag. You need to get some scope stuff. You need a backup little suction thing that runs independent of your vacuum system in case, electrical goes out. So there's a whole list that they give you to purchase. So I'd say kind of all in, I don't know, maybe it's like an extra like $10,000 of additional equipment and things you need to buy for the practice. Mm-hmm. But if you're doing oral sedation, you're already going to have about half of that stuff. So the entry into it isn't as painful. And then if you look at the delta between what you were actually charging the patient at $500 per hour versus what it costs you at about, $500 in total for the case versus $50. I mean, that $450 delta makes up the initial expense pretty quickly.
Yep. Cool.
Awesome. I think we might have, we do have a couple more slides here. So I'm going to go back one or two. Okay. So again, we kind of based on, if fluid is injected into different areas, what you can look for. If there's a hematoma on the arm, when you take the IV out, you want to compress that area really, really firmly so you don't have a bleed into the tissues and cause a hematoma. Air embolism. This was one actually that surprised me. So at the course, I see one little, ball of air going through the tube, and I look at the anesthesiologist like it's a movie. It's like, oh, the patient's going to die. And he's like, dude, don't worry about it. You can't empty the whole tube of air into the patient. That is a big, big problem. But there's like one little drop of air. Don't worry about it. So when you have your line running, you got to keep you got to let all the saline run all the way out and kind of work all the little air bubbles out of it. But if one little air bubble gets in there, don't worry. Because what ends up happening is the venous supply will go back into the atria, and then it goes through the lungs and gets filtered through the lungs. Now, again, there's a note on here that says 15 to 25% of patients have a patent foramen ovale, so essentially connecting the two atria together. So then the air bubble can go across the atria, bypass the lungs, and then it goes into the arterial system. And then that's when you can have, something serious occur. But for the vast majority of it, if a small little air bubble goes through, don't sweat it. Just make sure you run your entire line and you're not introducing a whole lot of air back into the patient. And then some basic numbers for you guys to have, 60 to 100 beats per minute for the heart rate, the ECG or EKG saying the normal sinus rhythm, pulse ox at 95 to 100. Blood pressure 120/80 or 110/70, capnography unit or respiration rate. You just watch how their chest will rise and fall, and you just count that at 10 to 20 per minute. And then temperature, you got your temperature ranges. I'm not necessarily doing temps in my practice though. And that actually, is that the end of it, Chris? Do we have a QR code? Here we go. So Chris is the king of QR codes. If you are interested in the sedation course, it's actually a pretty cool thing for me. It's because my brother is an anesthesiologist and he is going to be teaching the didactic component of the courses. And he manages all the complications at the hospital, at the UCI hospital. And my older brother, he's been doing it for a long time, and he has, some of the best work ethic I've ever seen. So I'm excited to have him come on board and kind of teach this stuff from his vantage point, because his understanding of it is so profound. So we're going to be running our courses, the first alpha course, and we have to keep it small for this initial one. So I think we're going to open it up to 10 or 15 docs, where we're going to have June virtual, July virtual, because we're going to try to be as respectful of your guys' time as possible. And then in August, you'll come out to Colorado, and we're going to do hands-on stuff with mannequins and all that, and some instruction and phlebotomy training, and just like a lot of the hands-on stuff we need to know. And then you're going to come in September, and we're going to coincide it with one of our Colorado Surgical Institute surgery courses. And so you'll actually have a component of your 20 live cases on actual surgeries, on actual patients who are undergoing longer surgical appointments. And no knock on all the other guys who are teaching IV sedation. My personal experience was, we were doing fillings and then sedating the patient for, 10 to 15 to 20 minutes, and not truly understanding the usages of Versed and fentanyl and how the blood pressure goes in a surgical environment. Or they had us doing prophies. And because it's just a numbers game for some courses to get you credentialed, we're approaching this from the perspective of, hey, we want you to have like a true experience of what you're going to have in your practice on these patients as well. So I'm excited to roll out our sedation course at the same time as our surgical courses.
So the June and July kind of virtual didactic portion, is that at your own pace, or is that, how is that going to be administered?
Yeah, so we'll roll it out over the weekend, but you can at least do it from home. It can be at your own pace, but what we find people do is at your own pace means like, half an hour, or playing it while you're driving and not fully absorbing it. Mm-hmm. So we really want you to take it seriously when it comes to like, hey, this is the information and stuff we need to learn to do this properly. And then also when the inspector comes to your office, he'll ask you a few questions. There's like a little quiz he gives you. If you didn't really pay attention to some of the didactic stuff, you might not sound like you know what you're talking about. So we want you to pay attention to it. If you can allocate some time, you can still pause it and go downstairs and kiss some babies, or go do what you got to do and be dad or be mom, and not turn the whole weekend off. But usually knocking it out at a good pace is recommended.
Thank you.
Yeah. And then over here, we're going to keep adding to this. So if you reference it in a week or two, we're updating consent forms. We got some marketing stuff to send out, codes and different things available. And then also within DSN, if you guys need anything at all, if there's anything you want us to create, or anything that we have created that we haven't posted, we're more than happy to add it to this database for you guys as well.
Great. Well, that was awesome. Thank you so much, Dr. Dhoon, and thank you, Chris. We will be posting more specific information about the course as things get closer, but count on virtual for June and July, and then the hands-on in September.
Awesome.
Right?
Appreciate you, man.
All righty. So everybody that's live, thank you guys for hanging in there. Make sure that you submit the questionnaire so that you can get your continuing education, and Ashley will be able to help you guys with that. And other than that, look out for some courses that are going to be posted for some upcoming CSI courses. The March course is completely sold out, but we have a May course that with some spots available for all on X implant placement, and maybe some wisdom teeth stuff. And keep the TPL event in Houston in mind as well. All right, guys. Thank you guys so much. Ashley, you want to take it over, or do you want me just to end it?
I think we're good. We're going to email that out to those who were live here. So you'll get an email to get your CE. Okay.
Okay. Thanks, guys.
Okay.
See you, Dr. Dhoon. Thanks, Ashley.
Yep.
Bye, everybody.
Bye-bye.
Hey, Chris.